Awesome. And just a reminder to please mute yourself during our webinar today. If you have any questions along the way, go ahead and put those in the chat and we'll get to them during the end at our Q&A time. So just a brief look at our agenda here. So we'll do a land acknowledgement, some introductions. We'll switch over to the presentation and we'll wrap up with some Q&A time. So to start, this is our land acknowledgement. QuitNow serves the entire province of British Columbia, spanning lands built on a complex history of colonization. These lands have belonged to diverse First Nations, Métis, and Inuit communities since time immemorial. We are grateful for the privilege to work, live, and play on these lands today. If you feel comfortable doing so, you can put in where you're calling in from today. So I'll go ahead and introduce myself. My name is Beth Clark. I manage the behavioral coaching and outreach for QuitNow, which is housed at the BC Lung Foundation. I've been in this role for about 2 years. I have a background in health promotion, as well as being a health coach and receiving my master's in public health from Simon Fraser University. I'm a settler to Canada of European descent, living in what's known today as Burnaby. And I'll go ahead and introduce our presenter for today. We're grateful to be hosting Dr. Nancy Poole. She is the director of the Center of Excellence for Women's Health, a research and knowledge exchange center that collaborates with service providers, policymakers, community-based advocates, and other researchers across Canada and internationally on both policy and health service improvement research that's related to women's health and gender equity. Nancy has co-led system change initiatives and co-developed guidance on trauma-informed practice and recovery from substance use within agencies, educational institutions, and governments across Canada. She is also the research lead on prevention for the CAN-FASD Research Network. So at this time, I'll hand it over to Nancy so that she can present her slides.
Thanks, Beth. Really happy to have the chance to speak with all of you today. Just got to figure out how I move the slide along here. Sorry. Here we go. So I'm going to just say a minute's worth about the work of the Center of Excellence for Women's Health and our approach on sex, gender, and equity-based analysis, and then talk, as the session said, a bit about what we've been doing lately around keeping up with what's happening around the cessation work on women and tobacco and pregnancy and postpartum specifically. So here we are. For those of you who don't know us well, really encourage you to connect with our site about the work we've been doing on tobacco for many years. Really trying to think about our research on nicotine and vaping in particular in this session, highlighting some of the more recent work we've done. But many of you may know us from past work we've done. And Joan, I see Batorf is here. She will recognize, especially as she led the work on couples and smoking that we did some time ago. But we're very much interested in that idea of closing the loop between research and practice, and really trying to make resources that are helpful for you as service providers delivering programming around women, nicotine, and tobacco. So lots to talk about. Really encourage you to go to our site and look under recent work, substance use, tobacco, and nicotine, and you'll find decades of work on women and smoking, some of it relating to breastfeeding and pregnancy, as we're going to talk about today. Just want to spend a bit of moment about how we do this work around focusing in on women and gender diverse individuals and men, boys, girls, all genders, through using this approach of sex and gender based and equity analysis. So really critically examining research, data, information, and experience relevant to substance use for consideration or omission, because lots of it is omits attention to sex, gender, and intersectional factors like age, race, region, or income. And then really spending time describing those impacts, as I'm going to do a bit today. And generating ideas about then what should we do based on what we know, and of course continuing to think about that as we go along. So here's where we've come to in terms of key sex and gender related factors around women and tobacco overall. I'm not going to go through these in detail. A lot of them are covered very well in this info sheet we have prepared on women, nicotine, and tobacco, but just recognizing that there are biological issues like hormonal and inflammatory responses that may influence cessation outcomes, particularly when paired with mental health concerns such as depression. Really a lot, when we talk about gender, we're not talking about gender identity only, we're thinking about gender roles, gender relations, and how institutionalized gender play out. And you can see examples from each of these here. Just about, things like for young women, appearance, self-image, and physical fitness strongly influence smoking and cessation decisions. Smoking may function as a coping strategy for gendered stressors, including poverty and caregiving, violence, trauma, stigma, discrimination, etc. So a lot around gender roles plays out. Gender relations, I've done a lot of work on violence against women, speaking to women about how exposure to intimate partner violence and lack of partner support really makes a difference. Lots about structural barriers. So really a rich field that I can't go all in on today, but we have written a fair bit about that you can read more on. But today we're going to focus in on these sex-specific life stages like pregnancy and postpartum, and also perimenopause and menopause, which I'm not going to talk about today, but also that a sex-specific life stage that create unique biological risks and opportunities for cessation. So we did a recent environmental scan that looked at what's around in Canada for women and tobacco in general, and also including pregnancy. And I just wanted to spend a couple of slides talking to you about, sorry, wrong direction, about what we found there. We didn't find a lot of women-specific smoking cessation programs and interventions. One in Peterborough, a couple of great studies being done by CAMH and Dr. Osnat Malamed, some work in Newfoundland and Labrador, lots from Nunavut and Ontario more, especially with the Canada prenatal nutrition programs. And those of you in BC do know that we also, the BC Association of Pregnancy Outreach Programs has paid lots of attention to tobacco as well. But just really interesting how little there is. And I'm happy to talk about any of those in more detail when we get to questions. Here's some of the Canadian online resources we identified, some of it from our own center, but also from Tobacco Free Nova Scotia. And there's pregnancy-specific things from CAMH in Ontario, and the wonderful Pregnets program that Dr. Peter Selby has led for many years. Obviously, QuitNow CA. Best Start in Ontario has tobacco resources. Nunavut has some attention on their website. Alberta, with their Ready or Not preconception site, has some great material, and also the Smokers Helpline in Newfoundland with very online resources directly addressing tobacco and pregnancy. So that's what we identified as being around there. But we also did a focus group recently with women with funding from the Society of Obstetricians and Gynecologists of Canada. And I just thought you'd be interested in what women smokers said to us from the focus group, that they valued emotional and peer support as much as clinical care. And found that online communities and peer groups helped reduce isolation, anxiety, and depression. We also found that there was still fear of judgment and some sense of felt lack of compassion and care. And they did, participants often still felt stigmatized, looked down upon or judged, which of course, interferes with interactions. And oftentimes providers really focus on risks as opposed to steps for change that really deepened that sense of judgment and shame. And they identified lots of information gaps and really wanted positive resources. They went online and struggled, they said, to find balanced, accessible information, and really felt that a lot of the resources were either too medical in orientation or lacked practical quitting advice or coping strategies, and they wanted more encouraging content, they said, and lots of support from peers with lived experience as well as doctors. So I just thought that might be interesting in terms of guiding your work. So they wanted healthcare providers to use empathic and understanding communication. They wanted emotional support as well as medical guidance. They wanted easy to understand, visually engaging resources that focus on coping strategies, mental health, and motivation, not just the risks of tobacco use. Social media was viewed as an effective way to reach them. They wanted stuff on YouTube and TikTok, and they wanted educational video clips and peer testimonials, etc. So really, I think a shift from when I started working on these issues many, many decades ago now, to a whole more immediate sort of peer-focused orientation. And they recommended booklets, blogs, video clips, and text messages even to provide support. So just thought that was a really helpful thing for us all. And we're using this in the course of developing an intervention I'm going to talk about in a minute, the liberation intervention. But we just thought all of us could benefit from this. So I was glad when Beth invited me to speak. I just wanted to mention as well a bit about some of the resources we have created at the center that are not only about tobacco, but also about cannabis as well, and about vaping as well. And there some of the resources we've created are on this idea of vaping, but trying to think about, and interestingly enough, aligning with some of the things the women have just said to us in those recent focus groups, of just trying to answer questions in a really collaborative way, trying to make it easier for women to feel respected. They have real online questions, at which we attempt to answer from the evidence as best we can. And there's a provider resource as well in that series, also downloadable from our website, that just tries to, give some more fuel for you as providers about reasons, how to hold conversations, lots of client handouts that you can share, just around tips and tools for managing use and reducing harm, etc. So trying to do that thing that we later in the focus groups found was exactly what women have been asking for. But in general, I just wanted to say we've written a lot about different aspects of substance use and pregnancy, including a lot of different substances, and always tried to include tobacco in with all the other substances, rather than isolating it over in a corner by itself, but really normalizing it as a drug of problem or a substance of problem that women may want to be thinking about shifting, making changes, either harm reduction changes or cessation changes, especially in the pregnancy and postpartum context. So really, just really hoping that we all can join in on making it something we talk about with all substances. Another resources we've created is called Doorways to Conversation, which just talks about grief intervention overall and how we can do that, and questions or comments you might make that really come from a client-centered, women-centered, patient-centered, whatever term you best use, strengths-based, harm reduction-oriented, motivational interviewing, trauma-informed, culturally safe, Indigenous wellness-oriented, and intersectional social determinants of health frame. And it's a lot. And that's why we've created some ideas about how you can have that kind of multiple orientation as you're doing it. I'm just going to talk quickly, just touch on the fact that as we were researching the liberation program, which we're now developing, we did do a recent scoping review of interventions. This will soon be on our website. If you're interested. The question was, what smoking cessation interventions, including peer-facilitated approaches, have been implemented for low-income women, and how do these interventions address equity, diversity, sex, and gender factors? And we found a number of studies. You can see a lot of them were really interesting. 139 of them dealt with smoking in the context of living with HIV, being a disadvantaged mother economically, LGBT smokers, adults in general, pregnant and postpartum women, postmenopausal women, and families with newborn dyads. So there's, stuff starting to appear. I'm not going to spend time on this, but right now, because, it's a complicated, long story. Many of you are well aware of the kinds of interventions we found and how we grouped them goes, as you can see here. Our work in developing the liberation one was especially of special interest around the technology-based and digital interventions, because we are trying to create this online tobacco reduction for low-income women group that will take place virtually in partnership with women's resource centers from all across Canada. And it's building on a virtual intervention we've developed recently with funding from the Public Health Agency of Canada that's about the dual intervention on intimate partner violence and substance use, where we develop both a workbook and an intervention group. Now, this, however, in being done in partnership with women's resource centers, we are trying to make this design this so that it can be led by peers. So again, it will be a virtual intervention and with these kinds of goals to reduce tobacco use amongst low-income women who smoke, increase their knowledge and access to treatments, promote continued cessation, reduction, and relapse prevention after the intervention ends through the resource centers and through text messaging, in ongoing text messages, and improves smoking self-efficacy and low-income women's ability to manage financial and emotional stress, and to really partner with women's resource centers, tobacco cessation services like yourselves, healthcare providers of all kinds, with knowledge products around smoking cessation for low-income women who smoke. So I thought you all might be interested in that, even though it's not specifically on pregnancy as we're talking about today. But I think obviously pregnant women can be part of this as well as other low-income women. But really trying to hone in on that group of smokers who are really have often not had support that they felt they can connect to really effectively. So just coming back as one last slide here, back to this info sheet, just really encourage you to use it if it's helpful to you in the context of your work. We went back to the literature and updated one that was older and on not only tobacco, but also on alcohol, cannabis, and prescription opioids. And really tried to summarize what we know from the evidence in a way that would be helpful to you as providers. And in some cases, you might want to share this with women themselves. It's not meant directly for women themselves. It's meant for you to make sure that you feel confident that you have the most up-to-date information available. So that's it. Just wanted to zip through so we had some time for questions.
Thank you so much, Nancy. That was very informative. Yeah, so we'll open up the floor now to any questions you might have. Go ahead and either unmute yourself or put it in the chat. I did have a question about the last one that you showed about the low-income women who smoke. Was vaping included that study too, or just smoking?
Pardon me?
Was vaping included as well, or
yes,
smoking?
yes. Okay. But vaping is a harm reduction to smoking. The focus is on tobacco smoking and helping women stop that. And vaping will be included as harm reduction in that process, with all the caveats of how much success that does create or not create. But yeah, definitely include that. And also, lots of stuff on NRTs and other things that could be supports to women. Also mindfulness, also walking, just really trying to connecting to culture, all the possible things that can be helpful as you're going on that path to stop smoking. We have a quiet bunch today. Yeah.
Can you see the chat there?
Yeah, it's yes, we will at some point do an event where we share the design. We're still designing it. For the moment, it's a research project funded by Health Canada over the next 3 years that is meant for us to pilot, test, etc., this intervention that we're building that is based on the research that I showed you today, where we looked at interventions for women, but really trying to come at it from this intersectional place where we can really build in all the various factors that affect women's smoking. So we're calling it liberation. It's a bit confusing because a number of years ago, we also created this guide called Liberation. That was a brief intervention guide for service providers on supporting women using motivational interviewing. And Chris Urquhart helped us from Change Talk Associates, helped us design this. So this is a previous thing. We're using the same name because it seems to fit so well for tobacco, liberating yourself in ways that is, perhaps not as even as relevant for other substances. So yeah.
There was one other comment in the chat. Somebody was asking if they had heard the term coercive conversation.
Yeah, came up as part of coercion, as part two ways in the context of those focus groups. One that that coercive control by partners really makes it challenging for women to stop smoking or to push them too hard towards smoking when they're not ready, depending on the partner's agenda. So there's coercive control happening there, but it also came up as a word from the focus groups that some people felt that their healthcare provider was a bit heavy-handed or coercive. They use that word in terms of trying to get them to quit, and really implying that, I guess, that they weren't interested in helping them unless they were gonna get there. And as we know, that isn't necessarily the best way of encouraging, supporting, and being trauma informed, I guess. Yeah.
Mhm. Definitely, yeah. Yeah, so we're just past 12:30. So if there's any other questions, feel free to direct it at us. But if not, we will follow up with a follow-up email with the link to this recording and some resources that you can reference as well. So yeah, I appreciate everyone's attendance today. And thank you so much again, Nancy, for presenting. We appreciate it.
Oh, glad to be offered the opportunity. Love to hear from anybody who wants to follow up in the context of their work. And glad if you want to share my email, Beth, with
I'll
anybody.
go ahead and share your email and your organization
Yeah,
website as well. Yep.
great. Thanks.
Perfect. Thanks, everyone. Appreciate it.